And let's look at the foot. We'll start with the calcaneus, upper left, the heel bone, where the calcaneal tendon attaches. Onto the talus, top of the foot, and this is going to articulate with the fibula and the tibia. In front of the talus, or we would say anterior to the talus, is the navicular. It's sort of a boat-shaped bone that articulates between the talus and the three cuneiforms in front of it. So the cuneiforms are going to be numbered 1, 2, and 3, beginning at the medial side. Now I know this is coming fast, don't worry, we're going to look at it later in this lecture. There they are, 1, 2, 3. So they are distal to the navicular, and they form a joint with the metatarsals in front. The cuboid shaped bone on the lateral surface of the foot. This is left foot, and there you have the tarsal bones, or the tarsus. Calcaneus, talus, navicular, cuneiforms, and cuboid make up what we call the tarsus, or the main body of the foot. Now, in distal to the cuneiforms are the metatarsals, which are sometimes broken when something rolls across them, or if we are up on our toes and move too far forward. Counting begins from the medial surface. Phalanges, plural, or flanks, singular. You notice the hallux, or the big toe, only has 2 joints, and the rest of them have 3. Okay, we'll get to the foot. I just wanted to show that to you because that's probably the trickiest part in this lecture. Okay, moving on. The femur, longest, heaviest, strongest bone in the body. It can still break, of course. It articulates with the acetabulum of the pelvis, hip socket, form the coxal joint. It is going to articulate with 2 bones in the lower leg, which I'll get to. The dislocation of a hip is rare because of that ligamentum teres. If you look at the lower right, you'll see the articular cartilage of the head of the femur and the acetabulum, and then there's that ligamentum. It's a marvelous joint that can last a lifetime. Because cartilage is alive, it's constantly being generated. Look at these joints in the middle here. We're going to get to these. Epicondyles. Just imagine a ligament attaching here. Patella. Okay. Below the head is the neck, and here it is up upper right. It's a site of fractures, that, especially in older individuals. If you look at the lower left, you'll see this happens sometimes after a hip resurfacing is done, or someone with osteoarthritis. They take a spill and it cracks right there. And sometimes, unfortunately, that can kind of contribute to the end of their life, depending on their condition. Look at these trochanters. There's the greater up here, and inferior to that is the lesser trochanter divided by the introchanteric crest. Now these are going to be sites for muscle attachments. The greater is a landmark for intramuscular injections. If you take your fingers and palpate, you can usually feel the iliac crest, the lateral side of your hip, and you just roll your fingers down a little, maybe 3 inches or so, and there is the greater trochanter, that knob. Below the trochanter is the troughened area, the gluteal tuberosity, which you might imagine is an important muscle attachment site, and it continues on to the linea aspera, linea meaning line. Condyles. Let's look at the lower distal end of the femur to the right. You'll see a lateral, well, let's do the condyles first, which aren't showing up here. Condyles, here they are. Okay, the condyles are going to be where we have articulation with the condyles of the tibia, which I'm going to get to shortly. Okay, so the tibia is going to be connecting, articulating down below here, the lower part of the leg. Superior to these condyles are the epi, think of epi above, and that's where the ligaments of the knee, because we want to keep this knee joint together, and we get lots of help from tendons and also this the ligaments of the epicondyle. Adductor tubercle, rough projection, where the adductor magnus attaches. So you'll see this right here. Adductor magnus is a huge adducting muscle, medial surface of the leg. Patellar surface articulates with the patella. Patella it's a type of bone. It's called sesamoid because take a look. If you can see kind of the middle lower, it's not directly attached to any other bone. And so we have a few of these. The hyoid, the tongue supports kind of that way. And there's some on the feet, sesamoid bones. And it's going to increase the leverage of the huge quadriceps tendon, especially the rectus femoris coming across there. The apex is the pointed part. I mean, it's not highly pointed, but it's more pointed than the other end. And there's on the posterior surface, posterior meaning kind of facing inwards. Think of posterior facing the condyles of the femur. That's the patellofemoral joint, and there's cartilage in there that they're not really showing in this picture. Now, I mentioned the patellofemoral joint where there's a stress syndrome, sometimes called runner's knee. And if you take a look at the far right, perhaps the best example, in a healthy knee, the patella is going to track along that patellar groove on the anterior surface of the femur. We can't really see it because it's hidden by the tendon here. But it's going to track inferior and superiorly. But in the stress syndrome, what happens is there's a lateral movement. And so it's going to drag across the condyles and scrape some of the cartilage. Why does this happen? Well, sometimes there's an overdeveloped muscle, typically the vastus lateralis. You don't have to remember this, but the lateral muscle is pulling it to the side, and so we have to develop the medial muscle to compensate that. Chronic scarring of this tissue. Again, they're not showing the cartilage in this image, but you get enough of that, you get chondromalacia, and that's a very common problem. If people have pain, kind of feels like just below the patella after running, then it's a good chance they have chondromalacia. It could be genu valgum, like a knock-knee position, but more often it's an imbalance of the muscle development. Tibia fibula, I mentioned these earlier. We call it the shin bone. The tibia it's a huge bone, but still it's one of the most frequently fractured bones in the body. And that's because its position is anterior lower leg, and that lower leg has lots of mobility. There's two, let's see, let's get up here. Here's the medial, lateral condyle on the outer side, medial on the inner side, and there's that intercondylar eminence, inter meaning between. Tibial tuberosity right here, and that's where muscles of the rectus femoris and some of the other large muscles are going to attach here. Down anterior border, the crest, we have muscles attaching there, superficial muscles, deep muscles. A fibular notch. Okay, the fibular notch is not showing up here, but there is a notch also, we'll see on the next picture, where the fibula articulates with the tibia. See, the fibula doesn't even get involved in the knee joint up here. It just becomes part of the tibia's functional stability of the ankle. Fibula, it's small and slender, and it's often fractured as well. Sometimes that's why we don't allow kicks from the backside in soccer or even football, hitting from the backside. This fibula, I think they call it slide tackle, if I remember right. Yeah, slide tackles. Okay. It helps to stabilize the ankle joint. I mentioned that. So even though it's not involved in the knee, really, it helps with the lateral malleolus. We call that the ankle bone. But that bony prominence, it articulates with the talus of the foot and articulates at the distal tibiofibular joint here. And there's a joint here where it joins the tibia as well. We do bone grafting from the tibia, partly because it's not such a crucial bone in terms of it doesn't support body weight. And so we can take the periosteum, which is a living surrounding, blood vessels, and the bone itself, and graft it to another body part. which is pretty slick. You know, it often works. Tarsus, and we start off the lecture with that video. The bones, let's just take a look at these. Talus, which is where the body weight rests. We have the tibia and fibula attaching here. The calcaneus, that's where a lot of the body weight is distributed. And in front of the talus is the navicular. And then the three cuneiforms, first, second, and third, counting from the medial side. Cuboid, that large cube-shaped. Metatarsals, also counted from medial to lateral. Phalanges, 2 on the hallux, the toe, 3 on the other ones. I might mention that many ankle fractures, for someone to say, oh, I fractured my ankle, it's often the tibia, because right here at the neck, okay, here's the lateral malleolus that we just looked at. And then above that's a narrowed part where fractures often occur. So in a sense, it's not the tarsal bones, the true bones of the ankle. It's more of the lower fibular or distal region of the fibula. We start off talking about the metatarsal bones, or the tarsus. And I've just gone through that. Metatarsal, yeah, I just counted through those. So let's take a look at the interesting story here. Fractures often occur when a heavy weight rolls across the foot, or here's a good, I like this x-ray. Here is a dancer on point. I know this quite well. I had a daughter that danced on point. And if they lose their balance and then all their weight goes onto the metatarsals, that's often when there's a breakage. Now, you don't have to be a dancer to have this happen, because sometimes we find ourselves in strange conditions. Like one student was walking and stepped into a drain, and her front toes caught just when she took a step. And wow, very painful. Breakage there. I mentioned phalanges or phalanx singular, numbered like the metatarsals, and the big toe or great toe is the hallux. Arches. These are there's really they do lots, but in some ways they don't do as much as people think. Right? There's some debate about this, but let's go through the standard story. There's a longitudinal arch comprised of two arches. One is the let's see where it is. The medial is the one I'm most interested in, because that's the high arch. It's going to come across the calcaneus, the talus, a little bit of the talus, through the navicular, cuneiforms, and the medial metatarsals. Okay, that's the one that gives us a high arch. And on the lateral side of that is similar, but it comes across the cuboid. So there's a difference there. And the two lateral metatarsals. Now there's also a transverse arch coming across perpendicular to that, formed by the navicular, the cuneiforms, and somewhat the bases of the 5 metatarsals, the front of the foot. All right, so two basic arches, and the first, the longitudinal arch, comprised of 2 kind of sub-arches. While we're talking about arches, let's talk about high heels. In a normal walking gait, about 40% of the weight goes on the ball of foot, 60% on the heel. But when you put on those high heels, then now the ball of foot's going to take 80% of the weight, and now we got a problem. Because the heel's only got 20% weight, and the ball of foot's not designed for that much weight, so it'll break down some of the fatty pads and the connective tissue, and it changes the gait. Now take a look at this diagram. Now this is kind of extreme, but you can see how, I'll tell you something, the foot is not designed for shoes. We're designed to walk barefoot. And when you start putting on shoes, especially tight ones, we have bunions, we have all sorts of issues. So go with something that's as natural as possible for your own welfare. Thank you.